This episode of Friends of Flo is brought to you by NCLEX Mastery. If you're a nursing student and you're about to take your NCLEX, you need to go to the App Store right now and download NCLEX Mastery.
Good morning, everybody, and welcome back to Friends of Flo. I'm Rebecca Porter.
And I'm Andy Whitters.
And we're very glad to have a visitor with us today, Professor Dominique Tobbell from the University of Minnesota. Dr. Tobbell is a professor and a director of the History of Medicine program, and we're delighted to have her speaking here at the university this week. So, Dr. Tobbell, Dominique, we're really glad to have you here.
Thank you for having me.
Yes, of course. Of course. Can you just tell us a little bit about yourself and the role that you have at the University of Minnesota?
Sure. So I have my PhD in the history and sociology of science, and I joined the University of Minnesota 10 years ago now, and I teach undergraduate and graduate students in the history of medicine, and we also have some med students who do some research electives with us. But basically, I teach a lot of pre-health science students, including nursing students, which is super fun.
Cool.
How did you make that leap from, I think your undergraduate degree was in biochemistry, and then all of a sudden here you are in history. So what happened?
That's quite the leap.
Yes.
That's quite the leap.
And certainly for those of us who work in the history of science and medicine, there are a lot of us who started off in science and then moved into the history of science or history of medicine. And I always loved science. At various times I thought I might want to go into medicine, and decided that wasn't what I wanted to do, but I thought I wanted to be a bench scientist. And as part of my undergraduate degree in the UK, I spent a year working at a drug company doing bench research. And, I was quite capable at it, but I really found it quite dull. I thought if I could just fast forward to being a PI where I didn't have to run the experiments, but could do the thinking, that would be okay. And so while I was working in the lab and watching my experiments run, I was looking at various PhD programs, and I thought I might do science journalism, but realized I didn't really know anything about the social or political context of science. And so in my looking for various doctoral programs, I happened upon the history of science and medicine, and thought, well, this is great. I could still get to read about science and medicine, but I really get to learn about what that social, cultural, and political context is. And so it seemed like a great fit.
Cool.
So that's how I made the transition.
Yeah. And can you tell us a little bit about your thoughts on the nursing history, both perhaps here in the United States and even globally?
But can I interject for just a minute?
Yeah.
Because I don't think nursing history is taught anymore in undergraduate programs, and I don't think it's being taught. Did you have any history in your DNP program?
No.
Really?
No, I did not have much history at all. In fact, I think
Wow.
I think a lot of the classroom didactics that we received throughout my nursing education has been more of an incidental sort of teachings, like, oh, hey, by the way, this is where a left shift comes from, like in a CBC. But that's more of a scientific example. But I suppose that the history of how many females are that have gone into nursing over the years, particularly in the American history of nursing, it was all just sort of supplemental information. There wasn't like a book that we read on it or a chapter we read. It was just like
really
our teacher would just sort of talk about it just supplementally.
So in my PhD program, we had a whole year-long course in the history of nursing.
Interesting.
And I got bitten by that bug. And my area of interest was ethics, of course, as you know, but to look at the history of how a topic is taught is really interesting too. And so when you're interacting with these undergraduate students, in particular, Dominique, what kind of questions are coming up, or what's the interest that people have?
So, the classes that I have a couple of core courses that I teach, and one is called Medicine and Technology in Modern America, and it looks at how healthcare became increasingly technological since the turn of the 20th century. And we look at specific technologies, but we also look at how the introduction of even technologies like the standardized patient chart transformed the ways in which healthcare was practiced. We look at, so in that course, we don't just assume that it's the physicians who are using the technology. We look at what technologies nurses were allowed in many cases to use. And so we talk about the introduction of clinical thermometry, and initially it was physicians who were taking temperature, and they realized, well, actually this is taking too much time. Our labor is worth too much for us to be doing this. So they delegated it to the nurse. And now obviously it's delegated
even further.
Yeah, even further. But looking at the ways in which the introduction of different kinds of technology transformed the way that healthcare was being delivered, who was delivering the care, how diseases have been understood, how diseases have been treated. And so that's very appealing to students who think they're going to go into medicine or dentistry, nursing, and our courses aren't required for anyone, but they are part of a major that feeds into the health science profession. So that's nice. And then I have another class that I teach, Women, Health, and History, which is very much focused on the different roles that women have played in healthcare as providers. So midwives, nurses, physicians, the struggle that women had entering the field of medicine, and as research subjects and as healthcare activists, particularly around the women's health movement in the 1970s, and also looking at the ways in which different diseases have been gendered. And so hysteria being really the canonical example, and why hysteria disappeared as a diagnosis, these kinds of things. And that attracts a good number of nursing students. And I think the students tell me it changes how they think about healthcare, both for those who are want to go into healthcare, and then just as potential patients or current, future patients.
Right. Well, we're all consumers of healthcare.
Exactly.
Right.
Can you, just for the pleasantries of our listeners, can you talk about some of those examples? Because so the diagnosis of hysteria, for example, I'm not trying to put you on the spot here, but that's a great example.
What was hysteria originally called?
I am familiar with a little bit about, but it's great to have a historical sort of expert here with us to maybe describe that particular diagnosis and
the gender and how it became gendered.
It was. I think the verbiage you used was, it was genderized, correct? But now it's of course just not an appropriate term, both clinically or politically. It's just a term that it's inappropriate. And so could you just maybe speak to that particular diagnosis, which I think is just kind of interesting, and especially in this day and age. So,
well, hysteria was one of several diagnoses, particularly in the late 19th century, that chlorosis was another one. Actually, anorexia, which had a slightly different meaning in the late 19th century. But these diagnoses that were typically given to women, young women. And for hysteria, some historians have talked about it as the wastebasket diagnosis.
Oh no!
If you look at the various symptoms from across the board, I mean, lethargy, frustration, body aches, but also agitation.
Right.
Maybe someone who was a radical would be diagnosed with hysteria. And these were diagnoses that were, historians have looked at the ways in which these diagnoses were given at a time when women were really starting to mobilize and be activists, like the beginning of the suffragist movement.
So when you look at the political and social context, it would. Okay, here I go in my feminist stuff.
This is what I thought would be interesting. I mean, how it relates to the movements of today. Because I think that to add to this, in the 1920s and perhaps even the 19-teens, I mean, you had this strong culture of subjugation of women, right? And so that was pervasive in the medical
and to a large extent, it still is.
Oh, well, indeed it is. And so, but to have a diagnosis of hysteria, just to describe,
talk about being labeled.
Yeah, right. To describe someone's frustration, and then to just, it's
it
so
gets into the whole. Oh, I better watch my soapbox here, but it really gets into the propensity for medicine to reduce everybody, and particularly women,
right.
to something that can get out of my office.
Right, and that's still something I think that goes on today. I mean,
Yeah,
just
but
like
let's
sort
go
of
back to hysteria.
overdiagnosing patients. But yeah, let's go back to this though. I mean, please continue your thoughts on this.
Well, I think this was a period in which physicians were for not just hysteria but chlorosis as well, which no longer exists. It was a form of anemia. Well, it's contested what it actually was, but the physicians were trying to be moral managers of their patients, and particularly young women. And so having justification for taking patients out of the family home and saying, let's put them in this clinical space where we will supervise them, we will control what they eat, we will control what they experience, and this is how they will get better. With hysteria, it was, there was all these different symptoms. It could have been different treatments suggested. And what I have an exercise that my students do in my class, and we have a wonderful history of medicine library at the University of Minnesota, the Wangenstein History of Medicine, Wangenstein Library for the History of Medicine and Biology. And I work with the curators there who bring primary source documents into the classroom. And so the curators, they identify articles that were being written, textbooks, things that were being written by physicians in the late 19th century, and they describing chlorosis, describing hysteria. Neurasthenia was another diagnosis, and that was more typically given to men. It was for melancholy, depression, these things. And so the students read all these different treatises on these diseases. They identify what the symptoms were, what the suggested treatments were, and they realize there's a lot of overlap, and that basically physicians are throwing all kinds of different treatments at these conditions, and they don't really know, nothing's really sticking. And so it really reveals to the students that this is a really contested diagnoses, or they are all contested diagnoses, and it's really just like physicians trying to how to make sense of these confusing symptoms. And to go back to that political social context, this is a period when begin early suffragist movement. Women are going to school, some are even going to university and colleges. And so this is a period in which the social role of women is changing. And so there's that kind of pushback of how can we, this sounds a bit heavy-handed, but I think that when women's roles in society is changing, they're going into the workforce, there are then social reformers who then push back and say, hey, there's something wrong with women. And medicine is one realm in which those arguments can gain traction. And this is a period when physicians are trying to claim their authority, because there's a lot that physicians don't know in this period.
Right. And I think society then and continues today is that medicine has claimed its moral authority in addition to its scientific authority. And when that final common pathway of authority, which often is the physician, gets challenged, it opens up that whole political, social context. And so when you get into, and going back to the 60s and 70s, that early post-World War II period, the evolution of the nursing education and the different pathways that were very complicated and continue to be so, that we were, for me in the 70s and in the 70s when I started my career, that there was a lot of pushback, particularly from physicians who were wondering why I was thinking and not just doing. And so I think it was a reflection of that pushback.
Yes, it's a really important point. And I think certainly throughout the 20th century, late 19th century, when nurses, the first training schools in nursing were introduced in the late 19th century. And since then, there's been a lot of that what nurses say that nurses need in order to be effective at the kind of care that they give. And sometimes that challenges physicians, that has challenged physicians' territory, and physicians pushing back about and having ideas about the kind of nurse that they want. And so there has been this tension within history about what is the role of the nurse? How do you educate the nurse? What kind of skills and what kind of scientific foundation does the nurse need in order to be an effective nurse? And, even in the early 20th century, nursing leaders were arguing that nurses needed to have more science education. And so we're incorporating more science into the nursing curriculum because and historians have shown that physicians were saying, actually, we need nurses that will think because patients are becoming complex and we aren't always there to interact in a particular clinical moment, but the nurse is. So we need the nurse to understand what's happening with the patient. The nurse can't diagnose, but we want her to respond. But I mean, really through the mid 20th century, there was a lot of assumption really that the nurse was really just kind of handmaiden of physicians. And I think nurses have never claimed that role, but think
it was one that was assigned to them.
Yes. And I think a lot of nursing education, particularly, most nurses prior to the 1950s were trained in hospital-based diploma programs.
Right.
And that model of education was very much based on the medical model. It was nurses getting lots of clinical education. They were working at the same time as being in exchange for the education they were receiving. So they were being taught procedure, and it was very routinized. The patient has this diagnosis. These are the procedures you do. You just do. You don't think.
Well, it was kind of an apprenticeship, yes. Which is how medicine started.
Absolutely.
Too, was as an apprenticeship. And then it changed. But Andrew, we were talking before the podcast started, and you were talking about what nurses in the graduate programs that you teach in are wanting and going more into the sciences.
Right. I think from my viewpoint in my career so far, which has been arguably shorter. I mean, I've been practicing now for 10 years. But I'm seeing this pattern where students are wanting, the DNP, the Doctors of Nursing Practice, are wanting more science-based information, evidence-based practice that is certainly more in the clinical vein, which is sort of goes against, I think, some of the current classes that are offered in traditional schools of nursing. That more pathophysiology, more biostatistics, more chemistry-based classes. So we as providers, then when we go out to the community, can sort of better understand the diagnoses that are out there that we are using to treat our patients. I think that there is there was a previous educational model of, well, if your patient has this symptoms, it's likely this, and then then we'll just kind of match it up like while you're in practice. And so I think that's that has encouraged nurses then to sort of think outside the box when it comes to their advanced education.
Right, and I think this is what Dominique was elucidating from looking back at how the apprenticeship model into more of the academic scholarship education of nurses. So
we left off in the 1950s. I mean, can you walk us through this evolution from like the 60s, 70s, and until today? What you're seeing, and then we can talk about the future then too of what nursing education looks like.
Well, after World War II, I mean, there was a lot of change within healthcare, and patient care was becoming increasingly complex. You had new pharmaceuticals, antibiotics, the first drugs to treat high blood pressure, new vaccines. But a lot of these pharmaceuticals had really complex side effects too. And then you have new medical technologies like kidney dialysis, the electronic fetal monitor, which nurses had a lot of responsibility for, at least setting up and then monitoring those technologies. New kinds of surgical procedures, open heart surgery. You get the first transplants in the late 50s, 60s. And so patient care is becoming increasingly complex, and patients are struggling with chronic conditions, cardiovascular disease, cancer. And so nurses realized they were having to make a lot of complex clinical decisions, and nursing leaders were saying, well, our nurses need to have a different kind of education. And so in the 50s, nurse educators reformulated baccalaureate education in nursing, and this introduced what is now the BSN, the Baccalaureate of Science in Nursing. There were previously baccalaureate programs in nursing, but they weren't generalist. They were really more for training those, giving advanced education to those who already had an RN through the diploma program. But the BSN from the 1950s onwards was really moving away from that medical model of the diploma program and emphasizing a nursing model of care, providing nurses with the science, not just the biomedical sciences, but the behavioral and social sciences too. There was a lot of emphasis on the behavioral and social sciences, and grounding nursing students in a liberal education on university campuses. And this was really to really kind of move away from that medical model to say we are independent expert practitioners. And so with the emergence of the BSN, and also in this time period, because there was a lot of concerns about nursing shortages, the community colleges emerged after World War II, and the associate degree in nursing was introduced in 1952 and there was Mildred Montag was the nurse educator who introduced the associate degree in nursing, a 2-year program, again, obviously based in community colleges. And the idea was that the associate degree nurse would be the technical nurse who would do a lot of the bedside body work of nursing, and the BSN prepared nurse would be the quote professional nurse who would do the other parts of nursing. And in 1965, the American Nurses Association said, okay, we want to do away with the diploma model. We want to eliminate the diploma programs, and we want to mandate that all nurses have to be trained in a collegiate program, so either associate degree or baccalaureate degree. But as many of us know, that didn't pass.
Pan out.
We still have diploma programs, and the debate over entry into practice has just been contentious ever since.
It's huge, and you talk to nurses that have graduated with an RN with the diploma or the associate degree rather. They are saying, well, what's wrong with what I already know? What's so good about what you do? And this mandate by 2020 to have the entry, I don't know about Minnesota, and the current status in Iowa is by 2020, 85% of nurses have to have a minimum, and so of a baccalaureate degree in nursing. And the resistance to that is still... it boggles my mind. I don't understand.
And I think you're right. I like the word you prescribed was contentious. I mean, it has been very contentious between I think your bedside nurses and your nursing leaders, where there seems to be an educational difference within those two roles alone. I've found that in my practice and observations that a 4-year educated nurse is always encouraged to go on into like a leadership role, especially in a hospital-based setting, whereas 2-year nurses are sort of said, well, we're just going to keep you at bedside. And so, and is that appropriate? And are we shooting ourselves in the foot, so to speak, by?
But if you're going, this is probably going to be a politically incorrect thing to question, but here I go. Why would you not go back to an apprenticeship, 3-year hospital-based or community-based 3-year diploma program, and then have that instead of a 2-year? I don't understand how you can learn enough in 2 years to safely practice.
Well, and this was actually something that the diploma-trained nurses and educators at diploma programs said. Actually, the diploma nurses are coming out way at a much better level, higher level clinically. And so, everyone's sitting for the same licensing exams.
Exactly.
So everyone has the
Exactly.
title RN.
Exactly.
Which
Right.
is crazy.
And so in the actual clinic, on the actual wards, the diploma nurses knew more clinically than the BSN prepared nurses.
Indeed.
But we had to, in defense of having a Bachelor of Nursing from 100 years ago, we had the same number of clinical hours as a diploma because you have to have X number of clinical hours to sit the exam. But it seems to me that it still is a contentious issue.
Oh, and sure it is. And so what is the future of this issue? I mean, where do we go 10 years from now?
So, I actually feel that the debates over entry into practice have in many ways been bypassed, and now the emphasis being on advanced practice nursing education, and the debates over whether the DNP is going to be the standard for education for advanced practice nurses. And that maybe is a little bit of a safer ground for nursing, because even though you have a lot of obviously a great number of advanced practice nurses who are master's educated and can quite rightly say, what's wrong with our education? I think the move is to have the DNP eventually be the standard for advanced practice education. And I think that for master's educated nurses, I mean, when in a lot of those programs where when the DNP was first introduced, the master's students were doing the equivalent number of credits as a doctoral student. And so in a way, you can make that claim like, actually, this is better for nurses. You're already doing that level of work that qualifies you for a doctoral degree in terms of credit. So we're not taking away from the education that you've received. We're just saying the education you received should have been rewarded and recognized as at the doctoral level. And of course, the DNP does provide other kinds of education and training beyond what the master's does. But I think when the DNP was first introduced, it was still contentious. There was a lot of pushback, even from nursing leaders that's really significant nursing schools were saying we don't want the DNP, but that tide has turned, and I wonder if that's just been safer terrain than that debate over entry into entry level practice. Right. And I mean, I do think again there's that push to have baccalaureate education be the standard of entry for nurses. But if the debate's over the diploma model or anything to go by, that it's going to be a long time before the associate degree moves out. And we have to recognize that the multiple educational pathways into nursing is really important for the career mobility and equitable access to nursing as a career. The BSN is 4-year school is very expensive.
It's daunting and expensive. Yeah. And so that community model is an avenue of access for a lot of people, and particularly for non-traditional people, adults in particular, who are thinking about another career. And 2 years isn't as hard to give up or pursue as 4 years and the cost.
So I think, moving forward, nursing leaders have to appreciate that there's a value and there's an important in terms of increasing diversity within the nursing profession and making it accessible to many types of people, and that so having the associate degree as an entry point has been really important and will probably continue to be in terms of the costs of education. Right.
Indeed. So we're going to take a quick break here. This is a good stopping point for us. We'll be right back after this brief message from our sponsors.
Here at NCLEX Mastery, we love nurses and especially nursing students, but we need your feedback about this podcast. If you have ideas on topics or you have questions you want us to answer, shoot us a message, leave a comment, go to our Facebook page, and just tell us what you think, because we want to help you in the most specific way that you need that help. Thank you so much.
And we're back. This is Andy from Friends of Flo, and I have my colleague, Dr.
Rebecca Porter.
Hey. And then so we have our guest with us today, Dr. Dominique Tobbell. Thank you again for being here. We had just finished talking a little bit about equitable access into the nursing career and the field of nursing. We've talked about different pathways, that is educationally, regarding the nursing career, 2-year versus 4-year, DNP being sort of the standardized approach, I guess, to the most advanced level of practice. Just wanted to see if you could talk just to the workforce issues. Do you see that the 2-year programs have contributed or help cure that issue, so to speak, within the workforce, having a need for more nurses throughout the years?
Sure. I mean, if we go back to when the associate degree programs in nursing were introduced after World War II, one of those, the main motivation for that was that there was serious concern, big concerns about shortages of all kinds of healthcare providers, but including nurses. And so the 2-year programs were a strategy for recruiting more more people into nursing and getting them through more quickly, being effectively trained. And so the associate degree nurses have been vital, I think, to helping to tackle some of those shortages. But I think studying the history of nursing and nursing education, you see that a consistent constraint on the production of the nursing workforce has been the shortage of nursing faculty, and the expectations that nursing faculty will be more highly educated, as nurses were expected to be more highly educated. So first with the associate degree in BSN, and then with master's level clinical education, then you needed faculty who could teach at that level. And so there was the call for more doctorally prepared nurses. And so I think one of the real challenges in dealing with the cyclical nursing shortages is that even as there are numbers of applicants being turned away from nursing schools and qualified applicants, nursing programs can't expand because they don't have enough faculty to teach the expanded program. So I think the associate degree program has certainly helped with shortages, but then there's also been that kind of top-down push. There aren't enough faculty to train them. And then with the lots of nursing faculty reaching retirement age, I think we've got even more concern about renewed shortages of doctoral faculty.
Yes.
That sort of also leads me into the issue of PhD education in nursing, and I know that that's a particular scholarly or a particular area of your scholarship, and your talk last night here was so informative. One of the issues is that I wonder if nurses are not thinking about a PhD in nursing, but there's this huge push for the DNP, and I think almost at the expense of the PhD program. What are your thoughts about I know we don't have another hour to listen to talk about the history of the PhD program, but what about the PhD accessibility and preparation and the wider acceptance in the academy of that nursing PhD?
So the first doctoral programs in nursing were introduced, first in 1920 at Teachers College, Columbia University, and then the 1930s at NYU. And those, even though the Teachers College program was a doctorate in education and the NYU program was a PhD, but both were very much heavily emphasized the educational model of doctoral education and weren't so heavily research-based. They weren't, even the PhD at NYU wasn't as thoroughly grounded in the research model of doctoral education. So after beginning in the 50s and 60s, nursing educators as well as health planners were saying we need more doctorally prepared nurses, and nurse leaders and nurse researchers and educators were saying, well, we need to introduce the nursing PhD, because with the move of undergraduate nursing education onto colleges and university campuses, nursing faculty wanted to secure their status within the university and be respected and regarded among their university peers. And obviously, the expectation at the university level, certainly in the non-professional schools, is that faculty have a doctorate. And even in the professional schools, the MD, the JD, the DDS. And so nurses argued we need to establish the nursing PhD, both in terms of making sure that we are recognized as academics on campuses, but also that we are doing research that's specifically geared towards nursing problems. So most doctorally prepared nurses prior to the 1950s had their doctoral education in education degrees and weren't really doing research focused on clinical nursing problems. The Nurse Scientist Graduate Training Program that was established by the Public Health Services Division of Nursing in 1962 paid for nurses to go get PhDs in the biomedical, behavioral, and social sciences. And the expectation was that they would then bring that knowledge back into nursing and apply it to nursing problems. But often happened, those nurses who then got PhDs in the basic sciences, and they stayed in those fields, and they didn't come back to nursing. And so a lot of nurse researchers and educators were saying we need a nursing PhD so that we can be sure that we have nurses addressing research questions of clinical relevance specifically to nursing, and that we can build a body of knowledge, nursing science, with which to guide practice and also future research. And so there was a real intellectual imperative, and particularly, as I mentioned earlier, the increasing complexity of nursing and patient care at this time. We need the nurse scientists to do that research, to generate the knowledge in order for nurses to improve patient care. So it was multifaceted. So I think the PhD has been incredibly important for building, expanding nurses' knowledge base, and for creating innovations in nursing practice. So PhD nurses have been critical for that regard, and I think also for securing nursing status on university campuses, so that they could go to committee meetings and be. I mean, I'm sure there were still prejudices and discrimination against the nurses, but they could say, hey, I'm a doctorate just like you. I can participate in this conversation. I'm contributing to the university's tripartite mission of research, education, and service. So I should be accorded that status.
Right. There's so much that we take for granted. You know, when you do a PhD, you go and do your PhD and get on with it. But it's so important to have that historical context to understand where we have come and then where we're going. One of the thoughts that came to my mind while you were talking about this was that technological revolution that happened after World War II, and then what's happening now, and the important. How does that PhD education compared at that time to now? Do you see a comparative analysis yet?
I think it's a little close to be able to, I think, draw a comparison. I think what I would say is that, you know, when I think about the role that technology has played and innovations in healthcare have played in the history of healthcare, is to think about what do those innovations translate to? I mean, we assume in America, and I think in other parts of the world, the assumption is that every new innovation means that it's better. You know, that new technology
is better.
Yeah, new is better. Hey, and as we know, the U.S. healthcare system is the most expensive in the world, and one of the things that Americans pride themselves on is that we have the most advanced high-tech medicine, and there is a correlation between the higher tech, the higher cost, and the assumption that if the technology is there, you should use it. And I think we need to challenge that assumption.
Absolutely. And the assumption that the outcomes will always be better. And we know that they're not.
Right.
And I think that, I mean, the shift towards high-tech medicine and highly specialized care has done a disservice to the importance of preventative healthcare, primary care.
I absolutely agree.
And which is lower cost, and lower cost in the long run too, because if you're doing preventative healthcare, fewer patients are going to need that high-tech medicine. So I think it's always important to question, just because we have it doesn't mean to say we have to use it. Who gets access to that new high technology? So is it about equitable access, or does it depend what insurance you have? And if you're on Medicaid, are you going to get access to high-tech medicine? And so what does that mean for equitable healthcare access? I mean, I think those are really important questions. And also, I mean, not the introduction of new technologies doesn't, it affects different communities of patients differently. So with the introduction of genetic screening, a lot of screening for genetic diseases prenatally, the assumption is, well, that's a good thing. We can understand, if we can identify problems before early and hopefully intervene, and whatever that intervention may be. But for when genetic screening was introduced for sickle cell anemia in the 60s and 70s, mass screening, and the assumption was, well, this will be a good thing. We can help prevent decrease the incidence of sickle cell anemia. But for the African American community, it wasn't a clear benefit, because this was could be read as another example of the American government and white Americans suppressing their communities, right, and not really factoring in what that history of racial oppression, and particularly by the medical community, what that meant. And so it's not always going to be a clear benefit. So I think it's important to ask what those costs and benefits are. And again, also who gets access, who as the provider has responsibility for the technologies. So nurses, as nurses, that it's actually the nurses who bear a lot of the responsibility for making sure those new technologies work, how they get maintained, that they're monitored, and I think kind of thinking about what new technology means for the different levels of providers who are responsible for that
I think
care.
I think a clinical example, at least in today's healthcare, and I see this a lot with labs that are being ordered. Nurses will be the first to question, well, why is it that we really need this? This is expensive. This doesn't really fit the diagnoses. And so like they're the ones who are usually trying to encourage a conversation about the patient's needs.
But I also think that this harkens to the importance and the relevance of advanced education. And,
of course, yeah.
And that we're talking about the role of the PhD nurse, that this is a really important role for nurses to consider early in their career about the research that is needed in policy development, in the ethics and the equitable distribution and access of healthcare, and the social policies developing. And it's really relevant for DNP nurses as well to be in the clinical realm and looking at this and having the knowledge and expertise to question this very use of the technology.
Yeah, I think that's critical because the whole one of the whole premises of the nursing PhD or of nursing, as I said earlier, is like to distinguish itself from the medical model that nurses they have a different theoretical underpinnings, they have a different focus than physicians. And so as the first generation of nurse scientists said, we ask different kinds of research questions. And so the nurse PhDs today are asking different questions than MD PhDs from other PhDs.
Yeah.
And so these are critical questions that nurses are uniquely positioned to address, particularly if they have that training in nurse science.
From a historical perspective, it would be a really wonderful project to look at the evolution of the research questions that nurses have been asking in PhD programs for the last several decades, and how has that changed and what has that impact been on patient care.
I'm interested in the holistic nursing care model. That seems to be you mentioned the underpinnings. That seems to be the underpinnings of DNP practice here in the States. Can you speak at all to that and how it's been developed? We'd been talking about how nurses think a little bit differently. We advocate a little bit differently. Can you speak to that just a little bit with the idea of the holistic care model, and then maybe just where that started to rear its head in history?
Absolutely. So your Friends of Flo, so Florence Nightingale really advocated looking at the patient holistically and in the context of his or her environment. And so I have to acknowledge that if we're going back to nursing history, that we can certainly see the arguments about considering the patient holistically back to Florence Nightingale. But the emergence of the nursing PhD, or the second generation of nursing PhDs, so the 60s and 70s, and this need to build a science of nursing. The nurse researchers who were working in the 60s and 70s were really trying to construct the boundaries of what is nursing science. And there was the nursing theory movement emerged when nurse theorists were trying to really identify what is unique to nursing and nursing science. And so there was a lot of conversation and publications and conferences around this issue. But by the end of the 1970s, nurse theorists had identified the 4 core concepts of nursing that distinguished and defined nursing science. And that was the person, the whole person, the holistic patient, the environment, the nursing action, so that nursing actions were geared towards helping the patient do for themselves. So it wasn't about doing for the patient, it was working with the patient. So really this emphasis on patient agency, which was really important in the 70s as counterpoint to reductionist, paternalistic medicine. And also the emphasis for nursing is health. It's not disease. It's not disability. It's not the locus of disability or disease. It's health. So seeing the patient on a health continuum. And so those were the four. So person, the holistic person, the interactions with the environment, the health being the emphasis of nursing, and that nursing actions are geared towards empowering the patient to be an agent in his or her care. Those were the four essential elements that were, by the end of the 1970s, nurse theorists and scientists have said, this is what defines nursing. And I think that even though research nurse scientists have maybe operationalized those concepts in different ways, I think that still continues to be that core element. And politically, it was very important because the 1960s and 70s burgeoning patient consumer movement, the women's health movement, and health feminists were saying medicine is reductionistic, it's paternalistic, it's basically saying everything that's wrong with a woman is a medical problem as opposed to being just natural. And so nursing could genuinely say, hey, we are very different from that. We are about empowering patients. We're about thinking about the patient within their biopsychosocial environment, this holistic approach. So I think that has been incredibly important for nursing.
Yeah, quite well said. Yeah, I've nothing to add to that. I think that's awesome.
The only thing I can think of to add is that it goes from that your phrase earlier today about medicine being a moral manager of particularly women, but for men as well, and helping people find their own moral agency. And it's very much a movement today as nurses help people with end-of-life care, with goal planning, and keeping their life at the focus of what's happening to their bodies on that health continuum.
I'm curious to go back to the history of technology and healthcare and nursing. Can you take us back to the 1920s here just for a moment? And can you give us an example of what was a cutting edge technology of that time, when because that's a time that I think of, that I know as standards of practice being questionable at the time. Like there was a draw into different practices of alternative medicines at the time. I'm just kind of curious as to what your thoughts are on what was considered cutting edge that maybe patients or some people in society didn't either have access to due to costs or to, of course, privilege. But yeah, just what if you could speak to that a little bit?
Well, that's a great question. And I think that a couple of the technologies that come to mind, and they were actually introduced a little bit earlier, but I think they were important in the 1920s. So the introduction of the X-ray was introduced in the late 19th century. And the hospitals were first acquiring X-ray machines like 1910, but they weren't really using them until the 1920s. So they had them because it represented the cutting edge of medicine, but actually physicians were expensive to use. At that point, you didn't have radiologists who were specialized in running the X-ray machines. So the physicians and hospital administrators had to figure out, well, who's going to be in charge of the X-ray machine? Who's going to run it? And so the infrastructure wasn't there to support widespread use of the X-ray machine. By the 1920s, they were called rentologists at the time, but what we now consider radiologists began to emerge as a specialty, and hospitals had created special rooms for the X-ray machine. They'd created categories on the patient chart that kind of standardized the use of X-ray. So that was by the 1920s. The EKG machine was also introduced in this early 20th century period, and that had a more rapid uptake, in part because the X-ray had set the foundation for how a new medical innovation could be incorporated into the hospital infrastructure. And so that was, I guess, another example. And whether it was being used diagnostically or not, that depended on the different hospitals. And of course, these were, we're talking about hospitals in urban areas, so like New York, Philadelphia, maybe in San Francisco on the West Coast, but in smaller hospitals, in smaller communities where they couldn't afford to necessarily have these technologies. And I think if we go fast forward to the late 1920s, the introduction of the iron lung for the treatment of certain forms of polio.
Indeed. Mm-hmm.
Very expensive technology that wasn't accessible, ostensibly had the potential to not be accessible to everyone. But then the March of Dimes Foundation was established to raise funds to ensure that iron lungs would be distributed across the country so that every community had access to iron lungs. And so it wasn't that every hospital had an iron lung, but that in the various areas that there would be enough iron lungs to support the treatment in those communities. And actually, I mean, go back to your earlier question about, or my point earlier about the costs and benefits of the iron lung. The iron lung was only useful in cases of, I think it was bulbar polio, so that impacted the intercostal muscles. That was the only form of polio in which the iron lung could help. And physicians knew this, but they were so helpless in the face of polio that even kids with other kinds of polio were still put in the iron lung, even though there was no way that technology could help them, because physicians wanted to do something. And so, again, that kind of raises the question, well, when should this technology be used, and should it be used by everyone with that diagnosis, that the kind of polio diagnosis mattered. But it also brings up, this wasn't going to be available to everyone unless this philanthropic foundation stepped in and raised a ton of money in order to help distribute and increase equitable access to the technology. This is I think kind of an exceptional example in the history of medical technology.
Well, and I think about today's examples of technology. They're particularly in the procedural areas of specialty medicine, like robotics. Not everyone has a robotic platform to do surgery, but the benefits of robotic surgery, I mean, if it's research, depending on where you're getting the information, it touts less pain, shorter length of stay, which all contributes to the bottom dollar of a hospital's function. So I'm curious, other examples you can think of today that where there might be technologies that are available that we might have difficulty accessing, and perhaps the technology, as we had discussed earlier, the technology is just too expensive and not necessarily worthwhile to put our healthcare system through the burden of having it there as an option.
I actually don't think I can. I don't think I can provide a good answer for that. I can't think. I mean, the examples I'm most familiar with are biological pharmaceuticals, which is maybe not the kinds of technology that you were thinking about.
But it's still technology nonetheless.
Yeah, I mean, absolutely.
So that's a treatment option that is indeed expensive, that not everyone in society might have equitable access to.
Well, you think of the biopharmaceuticals, exactly, and
so I think that's
cost,
a good example. Actually.
Yeah, actually, it's a great example, and I know that some of your work focuses on the history of biopharmaceuticals and the access to those, and the political relationships that exist to increase those costs and decrease the accessibility. Would that?
Well, yeah, but and even things like genetic counseling, like that's not every area or state or population has access. I think access to the appropriate technologies in today's day and age is a challenging.
I think the fascinating question yet to be answered, and historians in the future will be looking at this, is what is the impact and how was this technology, whatever it is that we decide to talk about, whichever piece of technology, how is it being used? I think about the electronic medical record. You spoke earlier about how the patient care record impacted the care that patients received, and now we look at the impact of the electronic medical record on things like privacy,
right,
and data mining, and those ethical questions, and the relationship with the patient. Has it changed because of the electronic?
Yeah, I would say those are all fantastic questions and
yet to be answered.
Yeah, and I mean, going back to what kind of high-tech medicine isn't, or technology isn't equitable and accessible to everyone. And I think the area of fertility medicine is a really clear example of this.
Great example.
Because insurance companies don't reimburse for fertility care. And so it's very much, it's very inaccessible to large segments of the of the population. And it's very much about if you have the financial means in order to get to go for IVF or other kinds of fertility treatment. And there's a lot of new pre-implantation genetic diagnosis is one aspect of fertility medicine. There's been a lot of innovations in the fertility field, and that is very inequitably distributed.
Having a child becomes a privilege.
Can you lastly speak to the EHR, to the electronic healthcare record? What is your opinion and observation on that from a historical perspective?
I think it's really important to situate it in the context of the changing of the patient record. Even, in the early 20th century, the introduction of the standardized patient form and deciding. And I know with the electronic health record, it's, a lot about it is what are the categories, what are the classifications that are listed on the electronic record. So as soon as you go from the 19th century where physicians would handwrite whatever their diagnosis was to an increasingly circumscribed chart that says you have to input it in using this particular language or else the record doesn't...
You won't get paid.
It won't recognize it.
Yeah, you're right.
For me, I've actually done a little research on the history of health informatics and the history of the electronic health record. And I know that one of the major barriers is interoperability. So even if you one of the arguments for the electronic health record is that it will be interoperable and that a patient can go to any healthcare clinic in different parts of the country, and that provider will be able to access that patient chart. We know that hasn't borne out.
Right.
The infrastructure, there's been limits with the infrastructure. There's, it depends what software that you use, which provider, which electronic health record provider you use. So there are really real constraints. So, and I think you ask any patient or any of us who've been to see a provider, and now the provider, whether it be a nurse practitioner, a physician's assistant, or a physician, they're sitting in front of the computer and they're not interacting. So that shift in focus, and that isn't unique to the electronic health record. With the introduction of new technologies into the healthcare environment, physicians and nurses' attentions were directed from the patient to the monitors. So this is particularly with the monitors that are introduced post-World War II, even the EKG. And so that shifts that provider-patient relationship. And so I think that raises real questions. And then you, Rebecca, you brought up about the ethics, the privacy concerns. And yes, electronic health records are such an important source for health informaticists, the data mining potential. So there is so much potential, but that
at what cost?
Yeah, at what cost? And whose data?
Right, and who does it belong to?
Well, I like what you said though about the having information be accessible like across the country, and we're still using 1970s and 60s technology by using the fax machine. It's like, so when I hear the word paperless, like it's a misnomer. It's a misrepresentation of what our system of medical information is, because it's not paperless at all. In fact, I would argue that in fact it probably generates more paper because there is that need still, and sometimes preference really, that providers want something that can fit in their hand as they read. And
I will say that the other take on the electronic health record, or another aspect of it that's important to consider, is for the patient that they're not seeing their entire electronic health record, but they can access their healthcare, the results from their medical exam electronically if they have access to the internet at home. And so I think that is increasing the information that patients have access to, and it's another medium in which patients can then communicate with their providers through that.
But that takes a fair amount of sophistication, particularly when you look at the aging population, that the older people, I don't want to generalize, but not access to that medium, and then understanding all that it is.
Indeed. Dr. Tobbell, we really appreciate your time here. We try to end each of our segments with words of wisdom for our audience. Do you have anything to add? Any words of wisdom, advice you might want to share with our audience?
Study history.
Study.
Amen.
So as not to repeat it in some cases, I would imagine. Yes. Okay. And this is Andy Whitters telling you to innovate, agitate, and educate.
And this is Rebecca Porter telling you to keep your stick on the ice.
All right. Thank you, guys. Friends of Flo out.
Friends of Flo is brought to you by NCLEX Mastery. Go to the App Store right now, download NCLEX Mastery, and before you leave, if you could just share this with your nursing friends, tell them about us, leave us feedback, go to our Facebook page, tell us what you liked, tell us what you didn't love so much, be nice. But thank you so much. We really appreciate you.